Good morning. Welcome back to the second session of the day. And it's really, what should I call it as, great to speak at this session going on at heritable movement disorders. And when Professor Simon asked me to talk about scrapping the copper, I really got confused. What does he mean by that? He told, you are going to scrap the copper. And this is what I started with when I started to look into it. I know that please don't call up that number for any chance and don't report me to any of those things, whatever is going on. And this was anxious moments to start my talk. Then I did ask, what should I do? He did think about something which you should talk about that. Then I told, this is something not a rare disorder, it's a very rare disorder. And does it require a plenary session where I should be speaking to about all the guests of the session here, where about 5,000 people are sitting now here, I am expecting. Probably a practitioner is going to see a case in their lifetime, and let us say a best of the best Wilson disease care centers can have about 100 new cases down the time. Is it worth it to have it? But yes, it makes a lot of difference. Why it is? Why we should consider this talk to be at where everyone should hear it. There are two reasons for that. One is this video, what it should show. A child who is completely bedbound, completely dependent for every day-to-day activities of life, and with your intervention, a person can lead a near normal quality of life. It is so satisfying sometimes, especially in movement disorders clinics, and especially most of us when we are catering to the elderly populations, this makes a significant happiness for you when you treat these things. Not only that, the most important point I should tell that this is a disorder where the seeds of today's conference was laid down. This is the disorder where the genesis of probably the extrapyramidal system started to appear, and where it has ended up us having this big gathering of around 5,000 people who are meeting at the International Parkinson Disease and the Movement Disorders. Keeping all these things in mind, I do concur that this is the talk which all of you should have known. And still, if you're not got, I think many of you have understood, and these are the two important people whom you should be able to know them. If you know them, you already know what I'm going to talk about, what I'm going to cover, what are their contributions. And if you don't know them, definitely you're going to know about all these things over the next 30 minutes when I'm going to finish my talk down there. So I'm going to talk about Wilson disease, and I'm going to go in a standard way of how a disorder has to be covered. It's better that all of us start something, how things had evolved. It gives a lot of perspective about the disorder, how it has gone, and why we are at this phase of the disease, and how it helps us to see what we need to look forward for. The concept of this disorder started somewhere in early 1800s, where few case reports probably were published, where you have neurological disorders associated with some hepatic involvement was there. But till, let us say, in mid 1800s, the concept, it was overlapping with pseudosclerosis. And albeit the most important thing of this disease was recognized well before this disorder was given its name. The two important ophthalmologists, Bernard Kaiser and Bruno Otto Fleischer of Germany, both of them independently have documented corneal rings in the patients, albeit they have not attributed it to the underlying etiology or pathology associated with that. But the name of these two ophthalmologists' names still holds good for this rings, what we see in these patients with this disorder. So the major breakthrough or major change happened in 1912 when this person, Professor Samuel Kinnear Wilson, one of the great neurologists, who in his thesis published in the Brain in 1912, wrote about this 4 cases what he had seen by himself and 6 cases what he had collated from the published literatures and seen by other people, patients. The progressive lenticular degeneration, a familial nervous disease associated with cirrhosis of the liver. And it was so empathetic, nicely presented all the findings of the patients of these cases. Now this disease has his name, or the eponym of his name. Now we know this disorder by the name of Wilson's disease. And this is where we should. This is one of those videos of his collections, which is published in and is available in our historical section of our movement disorders website. Please, anyone those who are interested, this is a glimpse of that video which is available, but you can see the series of videos down there, those who are interested to see it. Albeit the concept of Wilson disease, the clinical descriptions came in the 1920s and 1930s. By between 1920s and 30s, it was known that copper was the culprit down here. Nothing major was happening in this disorder. And most of the things, it ended up with death after the diagnosis. And I should tell that the Second World War was one of the critical turning points in medical history where a lot of things started to change. And this was the time when various countries were looking for potential heavy metal poisoning, especially arsenic, which could have been used to see what type of antidotes or treatment we could have. And this was the time when the BAL, or British Anti-Levist, was found. And Professor Cummings documented that BAL could be used for patients with Wilson disease because it increases the urinary copper excretion and clinical improvement. Those who have been walking down the corridor down there, there have been nice videos about BAL treatment. What you can see, then the historical section of these corridors of our conference has been put up down there. And this was the beginning of the therapy for Wilson disease. I should tell definitely that I feel this was the most important person who made dramatic contributions, somehow under-recognized, I feel many times, especially at the movement disorders meet. Professor John Walsh, he is the one who reported that penicillamine, byproduct of penicillin injections, which people used to take it, used to promote large amount of copper excretion. He took it by himself to prove it that it works, and then started the whole journey for Wilson disease. He is the one who wrote the first papers on the penicillamine for utilization for Wilson disease. Then he came up with trientine, then later on tetrathiammonium molybdate. His contributions is something which we shouldn't forget and has been dramatic. This was the time in 1950s and 60s, a lot of things started to go forward. And in addition to this, I would like to take three other names down here who changed the picture of management of Wilson disease. The concept of zinc for utilization of management of Wilson disease, which Professor Gerrit Schaunig, who showed that copper blockage can be done with zinc and does improve the patients. And then the contributions of Professor Hogenrod and Professor George Brewer in 1990s made a dramatic understanding, which has now made as one of the mainstays for the management of patients with Wilson disease. Yes, being a hepatic disorder, liver transplants have started, which is considered one of the curative therapies and started in early 1970s. And the last piece of this puzzle was finished in 1993 when the genes associated with this were independently published by three different groups of authors in 1980, attributing it to ATP7B on chromosome 13. I'd also like to highlight, because these are the two books when I started to work on Wilson disease during my research stint as a research associate, made a lot of impact for me. And those who are early readers can start with these two books. I have a nice understanding about Wilson disease and to work forward from there. So knowing all these things, which covers up some aspect about understanding Wilson disease, how common it is. And I already told about in the first slide how rare it was. But yes, it's not so uncommon also. And there are quite a few hot spots are there where it can be seen, like the Eastern European populations, the South Asian populations, and the East Asian population, where quite a bit of Wilson disease is noticed. The global prevalence is around 1 in 10,000 to 30,000, but when you go into the genetic prevalence of these mutations, the number may increase up to around 142 per million population. So what happens? Copper is required. I'm not going to details about how the copper is stored and what happens with copper. I'm going a step forward from there, where we know that there is a genetic defect here. This genetic defect leads to hepatic copper transport protein dysfunction, leading to impaired copper transport from liver into the bile and reduced copper incorporation into the apoceruloplasmin. This is required to convert apoceruloplasmin into ceruloplasmin, and if that is there, this clinically can be seen as reduced serum ceruloplasmin levels. And when this happens, copper starts getting accumulated in hepatocytes and leading to hepatocyte lysosomal dysfunctions. And that leads to hepatocytic injuries because of reactive oxidative stress and other mechanisms leading to early asymptomatic liver dysfunction. Once this hepatocytes gets damaged, copper gets started leaking from these damaged hepatocytes, leading to movement of copper from the liver to the bloodstream and then getting accumulated into vulnerable tissues such as eyes, brain, musculoskeletal system, kidneys, leading to end organ damages down there. And finally, it leads to progressive liver damage and then, if untreated, leads to death. So these are the classical pathological changes what we see in patients with Wilson disease. The pattern of pathological changes do vary, and easiest way is to tell that histopathologically to look into hepatic copper staining the rhodomine or oricin positive staining, which can be seen on histopathological findings. So, what is the gene? What causes down here? We know that Wilson disease occurs due to an defect in chromosome 13q leading to mutations in ATP7B gene, and it is usually transferred in autosomal recessive disorder. It's a big span of 21 exons. Now currently more than 700 plus mutations have been reported till that. This 700 plus mutations, what you can see, this is the difficulty for us to get a direct genetic testing and get an answer for when you suspect a patient with Wilson disease, unless until you know what are the hot spots in your area or in your region. The type of hotspots, the type of mutations vary based upon different countries and different areas, what we have seen. And what we can see is the commonest mutations in the European populations has been H1069Q mutations, which account for about 30 to 70% of this Caucasian population, and commonly have neurological presentation with age of onset around 20 to 20, around the second to third decade of life. Whereas in East Asians, PR778L and P992L are the commonest mutations which are seen. We have been surprised, in spite of India being a very big hotspot for Wilson disease, and in spite of having high rate of consanguinity, there have been wide range of mutations which has been published from different parts of India, including Western India, where the common mutation has been PC271X, and these mutations have been different in different parts of India as such. So once we know the clinical features, once we know how it happens, it should be very easy for us to pick up a diagnosis down there. Probably, I'll tell you, for those who are first time seeing, this one slide should make you understand what we are trying to see in patients with Wilson, or how a patient with Wilson disease will present to us. These include the classical dystonic smile, what you can see there. Most of the children coming to your clinics with a nice smile, smiling and running around. Don't go away by this vacuous smiles, what people have it. And people can come up with completely bed-bound stresses. Other than these things, the teaching point is the thick KF ring, what you can see here, or the sunflower cataracts, even though it is almost highly specific, but occurrence of sunflower cataract is in a very small subset of patients, what you can see. People can present with myriad of symptoms, including just with hepatic dysfunction, behavioral issues, presenting with pathological fractures, or with dystonia or tremors. And this is very easy when you know this. But in a day-to-day practice, the presentation is not like that. Patients can present with just as a Parkinsonism type of a presentation, young onset Parkinsonism as a presentation, or people can present with some mild focal hand dystonias or non-specific dystonias what they're having, or an elderly person in their fourth or fifth decade with life presenting with mild tremors or with hepatic dysfunction. Your eyes have to be open. If person comes with a clear-cut set of symptoms or florid symptoms, it's very easy to diagnose these cases, but however, many times that's not the case. Our point is to pick up the cases at this time when they come with the earliest symptom for us. Unlike many of the disorder, I can't pinpoint to one single symptom, so I have made the list around here. There's no need to make a note of that, but I'm just telling you how different systems are involved, and where Professor Walsh has put it is that only the experience suggests that no two patients, I'll tell you, no two patients are ever the same, even in the same. That's what you should remember. If the presentation was so classical, probably a misdiagnosis wouldn't have happened as such. The presentation varies from system to system, and people can present with any of the system. It can be hepatic presentations, it can be neurological presentations, it can be renal dysfunction, endocrinal disorders, cardiac issues, or it can be hematological issues. So you need to keep an eye when you suspect a patient or a possibility is there, always keep in the back of your mind that whether this could be a case of Wilson disease if you're not able to hit on anything down there. So how common it is? What do we see? So it based upon the type of centers from where the Wilson disease cases are being represented, the type of leaning is that whether it's a neurological or hepatic type of presentations. What you can see, I put down the major series from across the globe which have been published till now, and depending upon the center, whether it's neurologically predominant or hepatic predominant can be seen based upon the centers where they are being published from. In common rule of thumb, what I can tell that hepatic presentations are common in the first decade of life, and neuropsychiatric presentations are common in the second decade of life to tell it. Professor Schönberg and Sterlib has aptly put it, probably much more easier for you to remember would be hepatic presentations may account for about 40% of the cases, neurological cases can account for about 40% of the presentations, and all other type of presentations can account for another 20% of the cases. So now we know all these things. So we know the symptoms, we know what are the type of presentation, how to diagnose it. The point of diagnosis is not straightforward. Even best of the best centers have been having errors, like where we have been working, where we looked into the diagnostic errors of patients presenting Wilson disease. We saw that, forget about being misdiagnosed at peripheral centers. We did notice that the misdiagnosis was happening even at the centers where the Wilson disease clinics were being run. Because the initial clinical presentations vary, many times we don't suspect it initially to begin with, and later on when patients start developing a myriad of symptoms, then it pops up, and when it pops up, you see that everything was fitting into the piece of the puzzle and you never made a diagnosis. So average delay in Wilson disease, what we have seen that is around 2 years, and the goal is, because if we can reduce this delay in diagnosis, better the outcomes, because this is a disorder where treatment is available, earlier the diagnosis, better the outcomes for the patient to manage the patient as such. So once you suspect, you have a high degree of suspicion for Wilson disease, what you should do. These are the tests what should be there on back of your mind. That is serum ceruloplasmin, looking for KF rings, 24-hour urinary copper, MRI brain in neurological presentations, genetics, serum copper, Coombs negative hemolytic anemia. I'll go to each one of them point by point just to give a glimpse how each one of them are important. Serum ceruloplasmin is a carrier protein. The best is assessed by radioimmunoassay or radial immunodiffusion methods, but most of the labs use nephrometry method. That's what you need to keep in mind. Average normal range is around 20 to 40 milligrams. Less than 20 is sensitive, but lower the value, more likely the sensitivity. However, it can be normal in many cases, even in some type of genetic presentations. It can be normal or normal in patients with protein-losing enteropathy, or lower in patients with protein-losing enteropathies and other type of nutritional issues, or some type of genetic disorders where also you find that ceruloplasmin levels can be on the lower side. So you should keep your minds open, because just having a low ceruloplasmin does not give you a diagnosis. It gives you a thought process which direction you should go forward. Serum copper is important, not for the serum copper value, we need to have the serum copper to estimate the free copper, that is the circulating free copper which is damaging the body tissues, which helps us to make a diagnosis what is going on. Probably among all the tests, 24-hour urinary copper will be more sensitive. It has directly indicates the serum free copper level, and more than 100 micrograms per day is almost diagnostic. However, it can be normal or less than 100 micrograms in asymptomatic siblings or in younger children. People do use not most of the centers, but some centers do use penicillamine challenge test, wherein they look for elevation in 24-hour urinary copper, let us say about 5-fold increase after giving about 500 milligrams of penicillamine or 12-hourly interval, and to see what is the threshold of copper excretion increases. So each one of the assays have their own advantages and their own limitations. Not one test is diagnostic here. But even the tests such as liver copper, which is done, which is probably considered, could be considered as one of the more sensitive, but it is invasive. False negative reports can be seen due to uneven distribution, and false positive can be seen in other type of hepatic issues. Next, coming to KF ring, probably this is one thing if you know and if you see it, probably there's nothing else to be done. It's the easiest way for me to put forward. It's the deposition of copper in the Descemet's membrane, and slit lamp examination is required to confirm, because you need to see whether this is deposited on the Descemet's membrane or it's on the stroma just in front of the Descemet's membrane. Because many type of hepatic disorders can have pseudo KF ring. This is a nice publication which has come from our ophthalmology unit in India, one of the ophthalmology units in India, where looked into all patients, young onset hepatic issues who had KF ring versus pseudo KF ring due to other causes, and they have nicely deciphered how this looked like. And this is one of the rare patients who had almost, the KF ring was so big enough, it was almost closing up the cornea, what you can see, that it's almost just sitting up down there. It's rare, but yes, something if you see like this, there is nothing for you to think about an alternative diagnosis, what you can look into it. In this era of genetics, I should tell that it should have been very cakewalk for us to have suspected patient of Wilson disease, send a genetic testing and get an answer and you know the answer. But in Wilson disease, it's not straight because there's a variant of hotspots are there, more than 700 mutations are noted. And currently, the standard genetic testing gives you around 50 to 75% of positive results. Means where you suspect and the diagnosis has come out. It may happen that clinically patient is still Wilson disease and your genetic testing has come out. So always understand how this genetic test needs to be interpreted and what are their values and how to work on that as well. There are other disorders where you have genetic type of presentations where yes, which can resemble Wilson's disease. I'm not going to go in detail, just a slide for someone who wants to have for a discussion at later on. Other than this would be, especially in this audience would be interested to look about the neurological forms, and we have noticed that in neurological Wilson disease, MRI could be one of the clinching diagnosis, or this is where you make a diagnosis. So you have a patient with extrapyramidal onset, you get an MRI done as a part of your regular workup, you see these findings, and almost invariably you know the diagnosis is there. We did look into young onset extrapyramidal symptoms, disorder patients, and we looked into different diagnoses, those who had different diagnoses, and how the MRI could have been helpful. And we found that patients with having face of giant panda, tectal plate hyperintensities, central pontine myelinolysis like changes, or concurrent changes in basal ganglia, thalamus, brainstem, almost invariably was diagnostic for Wilson disease when you found in this subset of patients. You have these tests, whatever I told you, but you don't know how to interpret it, right? Many times some of the tests are positive, some of them are borderline, some of them are negative. How to make it? This is where the Leipzig score and the modified Leipzig scores comes into practice, where all these tests are taken and you score, you give a point to them. And based upon that, you have a score of 4 or more and you make a diagnosis of Wilson. It's as simple as that. And we at the Indian cohort, Indian task force on Wilson disease worked, and we recommended for the Indian patients, the Indian subset would be to add up family history, divide ceruloplasmin into 2 further scoring points, less than 5, 6 to 11, and 11 to 20. We have removed penicillamine challenge test and liver copper because these were not standardly utilized for us. And based upon that, what we have found out that this test still holds good. And whenever you get this test, you can use this Leipzig score, modified Leipzig score, to see that how good you feel comfortable about your diagnosis. So now, once you have a diagnosis, now you know how to go forward, how to manage. So it's very easy, nothing to worry about. It's not like, it's so rare that no one has not written. It's so rare, but so important that everyone has written about this. This, we have now practice guidelines from the European Association of the Study of the Liver. We have India-specific guidelines, which has been an enormous effort from 3 different societies who were involved in management of Wilson disease. That is Indian National Association for Study of the Liver, the Indian Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and the Movement Disorder Society of India. All these 3 societies came together and made a guidelines for India-specific. And then we have the American Association for the Study of the Liver Disease who have guidelines. So you have ready-made guidelines, so that you can just follow it up and it will be very easy for you to manage. What are these includes for the management? One is disease-modifying therapy, and second is symptomatic therapies. Disease-modifying means where we are trying to see how to reduce the copper or how to avoid copper-related damages, and second is symptomatic, where already copper has deposited and caused secondary end organ damages or issues because of that, and how to manage those things. Penicillamine, probably everyone knows, this is currently the first line of therapy for management of Wilson disease since the time Professor Walsh has proposed it. It's a preferred line of therapy. Every gram excretes around 200 milligram of copper and also induces hepatic metallothionein. There's a concept of significant paradoxical worsening with penicillamine. Probably, I think these are all the patients with whom full dosages were started early. We have seen over a period of time, start low, go slow concepts works very good and helps. Very small subset of patients, probably around 5 to 10% may have paradoxical worsening. This mainly happens because there is release of the hepatic copper into the free circulation. Sudden surge in the free copper can happen, and that leading to various types of side effects. Similarly, that holds good for trientine, the similar type of side effect, but the understanding is that trientine has lesser side effects or lesser likely chances of paradoxical worsening as compared to penicillamine. The third most important is zinc. It works by a different mechanism. It acts by inducing metallothionein and induces increased fecal secretion of copper. So usually recommended dosage is around 50 milligram, 3-eyed times are around 150 milligram per day, or in children about 75 milligrams per day. Probably this is the first line of therapy for pre-symptomatic, and now it has become one of the standards for long-term management of patients with Wilson disease. Ammonium tetrathiomolybdate is another drug, which is a strong chelator, which is given, but similar set of side effects or similar set of benefits, similar, like penicillamine and trientine can be noticed. So which type of protocol should we use? I did see what Professor Hogenrad has been speaking about a lot about copper, because at the end of the day, we are trying to reduce the copper. Is it requirement is there to suddenly to take away the copper and then treat it, or try to take away slowly? Because what you do with decoppering therapies with penicillamine and trientine is, or ammonium tetrathiomolybdate, you take away the copper from the hepatocyte, put it into the blood and take it away. And when this surge happens, there's more likely chances that there's a secondary damage is going to happen and paradoxical worsening. Whereas in zinc therapy, this surge does not happen. It's a slow process and outcomes should be better. So different centers, based upon their own concepts, their own utilization, they use different protocols to management. And when we had discussion in our own task force, when we were sitting and talking, and we could see that every center had their own, even though the goal of therapy is same, outcomes or the way they manage is different. Aim is to reduce either by giving penicillamine, trientine, zinc alone, or a combination of both. And people have tried to look into it, compared effectiveness and safety of penicillamine alone or patients who are zinc salts. And what has happened over a period of time is some therapy is better than other. Over the longer time therapies, both of them have had a similar outcomes, or sometimes in certain subset of patients, let us say patients with have acute hepatic issues or primary hepatic issues, probably zinc has been shown to have better efficacy or better tolerability, and lesser likely chances of acute worsening has been noticed. In long-term maintenance therapies, zinc and penicillamine do hold the standard line of management. So it all depends upon how each center is looking into it. But at the end of the day, we are looking for good copper management. That's what you should remember. Pre-symptomatic patients, currently, zinc is a drug of choice, and patients who are presenting with acute liver failure, even though liver transplant is spoken at various levels, but currently it is kept only for a certain subset of patients where fulminant presentation can happen. However, we should remember that patients who are having very fulminant presentations usually have very poor prognosis and outcomes even after liver transplantation, what we have seen. In neurological Wilson disease, the initial publications, most of them were controversial, and usually it was considered that neuropsychiatric presentation may be a poor indicator. However, of late, the newer publications which are coming forward have shown that even neurological symptoms can improve and liver transplantations can be considered in patients with severe non-responsive patients with Wilson disease. Yes, other day I saw Dr. Laurent Kalia was speaking about newer therapies, including adenoviral vector-based containing human ATP7B mutations, which can have changed our metabolic control and correction of the copper metabolism can be seen. Newer therapies such as cell therapy to repopulate the liver with healthy hepatocytes are being considered, and somatic gene CRISPR technologies are being utilized. We need to see how they will come out and whether over next 5 years or 10 years we can have better therapies with lesser side effects and easily manageable for the patients. Coming forward, other than decoppering therapy, symptomatic therapies do vary from patient to patient based upon your own set of patients. For example, about 6 to 8% of patients with Wilson disease can have seizures, so you need to have managed them with anti-epileptics as required. Patients can have hematological presentation with hypersplenism, and then you may need to consider for splenectomy, or patients with having severe dystonias, botulinum toxin therapies. People have tried out lesioning surgeries for persistent cases. Like this is one of the cases where patients with severe tremors with Wilson disease, so a lesioning surgery was done with a clinical benefit. And even DBS is being done for certain patients who are having severe patients. Other than symptomatic and disease modifying, dietary copper management plays a crux because our goal is to reduce the copper in the body, we don't want to have unnecessary increased copper intake. So normal target is to have less than 1 to 2 milligram per day, but it's not so easily done as said because many of these have hepatic dysfunctions. We need to have protein-rich food, and most of the protein-containing food has copper, and it's not so straightforward. This is a slide what you can see, which are the high copper-containing food. And in India, usually we suggest, this is the recommendations or what we suggest for patients with Wilson disease, what type of a sample example of dietary recommendations for what we suggest for. And it has to be modified based upon each country's food and habits, and so that does help you out to management of those things. Coming to special groups, in special groups, yes, Wilson disease treatment, especially in young women, can have endocrinal issues or people during the childbearing age. Usually the recommendation currently is that no treatment has to be stopped, and usually people treated with penicillamine continues to have better outcomes, less likely chances of having miscarriages, and less likely chances to have as developmental issues in the children. So how to monitor? You have initiated the treatment. What are the things? First is clinical assessment. Probably prior to 2007, when we were publishing, we didn't have standard scales. We used to use the CHU staging, the neurological symptom score, or modified Schwab and England activities of daily living at that point of time. But from 2007 and 8, there are two important scales have come out. One is Unified Wilson Disease Rating Scale, and second is Global Assessment Scale for Wilson disease. Both of them are comprehensive enough. They give a holistic approach to see into various symptoms of patients of Wilson disease and manage or follow up in the long term to understand whether your therapies are going in the right direction and the patient is working in the right proper or not. More than that is to look for whether your treatment is working proper or not. Based upon the type of treatment is going on, you need to look into the serum free copper levels and urinary copper levels, which will help you to make you understand that whether patient is taking appropriate dosage or patient is over-treated or there is a non-compliance of the treatment is happening. Long-term outcomes are usually good. It's a well-recognized. Very rarely, few patients may go for liver transplants down the time because of acute worsening. We try to look into patients, whether we can classify them who can be poor predictors. It is very difficult to tell what we can notice because even the worst of the worst patients did become better, but some patients, they kept on worsening. What we found at severe MRI changes and strong family history, patients who had deaths already in relation to Wilson disease in the family, they are the subset of patients who usually had a worse outcome. People can change, in addition to biochemical changes, you can see brain MRI changes, KF ring vanishes down the time, even atrophy of the brain becomes better down the time. So the therapy changes and people do have good improvement over the period of time to remember. Finally, to scrap the copper, what I like to tell is there are 4 important things what you should remember. One is high degree of clinical suspicion is required. Without the clinical suspicion, you can never see. I don't see how many of you have seen Wilson disease also, that's the way it is. And confirmatory workup with 24-hour unicopper, free copper, slit lamp for KF ring will help you out along with utilization of modified Leipzig scores. Management with decoppering therapies, liver transplantation where required, and symptomatic therapies remains. The most important is not the diagnosis and treatment. Most important is monitoring, caregiver education, screening of siblings, free copper mud. This is what gives you satisfaction at the end of the day, whether your treatment is good, because these are the people whom you are going to follow for next 20 years, 30 years, and 40 years, where people are going to lead near normal life. Good. With this, I'll try to end my talk, and before I end, I'll try to thank few people down here. What you can see here, this is Professor H. Satnarayan Swami. He was the one who primarily started the Wilson Disease Clinic at my alma mater, that's the National Institute of Mental Health and Neurosciences back in Bangalore, India. And he has passed on the baton to Professor Arun Talley, and now Professor Sanjeev Sinha is looking after the Wilson Disease Clinic. And for the last 30 years, that has been enormous contributions. And in addition to this, I'd like to thank Professor Mohit Bhatt, who has been holding on the baton for the Indian Wilson disease picture over the last 20 to 30 years. And this is one of our Wilson disease clinic when I was working as a research associate down there. And this is the whole Wilson disease task force of India from the 3 societies which has formed down there. Thank you. Thanks a lot for giving me the opportunity.